James. I'm one of the F2s up in Newcastle. I'll give a talk today, just 15 minutes about orthopaedic careers. I think to give you a brief overview, I'll briefly talk about why orthopaedics, and then I'm going to go into the nitty-gritty about how to build your portfolio as a medical student, and the application process, and then how to typically aim towards scoring points for QIP, audit, research. And I've tried to give a bit of a guide for how I'd recommend you do it for each year of medical school. I've aimed to be really picture heavy and fairly interactive. I don't know how interactive we're going to be. If you want to chime in, I've got certain points for that. And if there's any questions, you're welcome to ask them at the end. So I'll briefly tell you a little bit about myself. I'm originally from Sheffield, so the hilly city. And I studied up in Newcastle from 2017 to 23, where as part of that, I did what we call an intercalation, where I did a Masters of Research in Aging and Health at Newcastle University. Before staying up in the Northeast as a specialised foundation trainee, doing particularly research at the Newcastle upon Tyne Central Hospitals, which you can see in the bottom middle photo there, which is a nice trust to train in. Well, I should be starting as an academic clinical fellow in orthopaedics from 2025 onwards. And so that's me. Now let's move on to why orthopaedics. And it's not just about bones and hammering. So I think there's a key way that I've looked at this, and I would recommend you can look at, while kind of keeping it personalised for yourself. So do you enjoy the theatre environment? Do you enjoy things such as fracture clinic? Because primarily as a kind of surgeon, that's the environment that you'll be spending time in. There's an old adage that if theatre is your favourite place in the hospital, you should maybe become an anaesthetist. And if theatre is your favourite place in the world, you should consider surgery. There's quite a diverse range of work. You'll train in many different subspecialties in lots of different tertiary and district general hospitals. There's quite a lot of technological advancement there. So we've got the advent of robotic surgery, elements of 3D printing, particularly in things in terms of, say, 3D printing replacement bones and imaging of joints. You get to do an impactful operations. So, for example, if someone comes into you and they need a replacement hip, they probably can't mobilize very well. They're having a significant impact on their quality of life. You can change that and you can send these patients home sometimes, a day later, and their life's completely changed. You actually get to do something that has real meaning, and which it means a lot to me versus some other specialties where it's about managing a gradual decline. And everyone's a bit different. Looking purely at also the nitty-gritty, there's a strong job demand nationwide for orthopaedic surgeons. There is scope for private practice down the line, but it's quite a long way into the future. And so it means that in theory, if you wanted to work, you could probably work in most areas of the country, and there'd be a job that you could, in theory, fill. I think key is that I've worked within orthopaedic teams. I enjoy the environment and the work, but I'm a foundation doctor. We'll talk later, Mr. Rao will talk later on about the details from a consultant level, because you probably don't understand orthopaedics. You probably might not understand orthopaedics until you're an ST5, ST6, ST7, or even 5 years into being a consultant. It's just about saying, do I enjoy this for the time being? Is this something that I want to aim for? So it's not just NHS work. In addition to working in the NHS, you can do things such as get involved in research, particularly wet lab research. There's elements of military medicine. So you can, I've got colleagues who are orthopaedic consultants who've been attached to the British Army during operations in Afghanistan and Iraq, as well as things such as motorsports medicine. So one of the, I don't know if you can see my cursor, but in the bottom right image there, one of my colleagues, one of my registrar colleagues, works for motorsports and was able to go to Silverstone as the orthopaedic kind of registrar on track side. So there's a lot of things in addition to pure NHS work. And the kind of overreaching advice that I'd give, I don't know what stage everyone's in, I assume somewhere during medical school, is that it's completely normal to be unsure what job you want to do for the rest of your life as a medical student. That's completely fine. I just narrowed down your preferences to something like surgery, medicine, anesthetics and critical care, and GP, and then target all of your portfolio preparation for these. You didn't come out of the womb wanting to become a pediatric HPB or transplant surgeon. Just find out what you enjoy, try and build a portfolio for it. And if during your foundation years or even later you decide, look, I don't want to do that, that's fine. You will have a portfolio that you can pretty much fit into any specialty. So just asking out to the audience, does anyone here know what a shadow curriculum is? This is essentially a separate set. I'm going to butcher this now, but this is an element of the curriculum that they don't explicitly teach. Okay, and a lot of the portfolio can possibly appear irrelevant to your day job, and it often is. But what they're trying to do is look for people who might be good orthopedic registrars or consultants down the line. And that's what I think each element of the orthopedic portfolio is trying to target. So I'll briefly discuss what an orthopedic training looks like. So you finish medical school, you do your foundation years, and then Scotland has its own separate, specific, competitive run-through orthopedic training. I won't spend too much time on it, and I'll focus on the one that is done nationally. Okay, so you go into core specialty training. You have to take the multi-specialty recruitment exam at present, score well for it, and then apply for core surgical training. And these can rotate through jobs including general surgery, ENT, orthopedics, urology, and at which point you get to kind of applications to higher specialty training. So you apply to be a registrar within orthopedics. So moving on to the portfolio, and this is specifically targeted for the core surgical training portfolio, because as I've said, essentially you're looking for your next step will be application to core surgical training. You've been given a map for what you should do to apply for CST and to get the portfolio points. So you just need to sit down and basically prepare for all of these. Keeping in mind that most of the things you score points for within the core surgical training are transferable directly to other jobs such as IMT, ACCS. And so keep this in mind. If you can go home tonight and then look at the core surgical portfolio for this year, maybe print it out and work out and target each area that you want to do. Keeping in mind, it does change year in, year out. It will probably change by the time you guys get to application to core surgical training, but this is the best guidance we have at the minute. So I'll detail some opportunities for mentorship and support later. But firstly, commitment to specialty. So this is two sections. There's firstly a thing called the e-logbook, okay? And this wants you to have operative experience. At the minute, the highest points you will get will be for assisting or undertaking 40 operations. What you need to do is you need to go on a specific Google e-logbook surgery. And this is it's kind of a multi-specialty way of logging all of the operations that you've assisted in. I think I've got some key guidance here, which is that if you're in your clinical years, attending your placement and just explicitly ask, can I assist in this in theatre here? Surgeons will almost always say yes, or if they're really busy, they may say no, but that's completely fine. What I would recommend you do is every time you assist in theatre, get a record of the things you need, such as medical record number and date of birth. It depends based on subspecialty which section you need. Go home and fill in the operation, because it's really easy to not do it if you're on a busy rotation, and a few weeks later you basically need to go back and you've forgotten everything that you've done. I've got at least 20 or 30 operations that I've assisted in that frankly I've just lost. Okay, and so that's my advice here. Try and organize student selected placements within orthopedics. So this requires, while you're in the hospital, asking people if they know any orthopedic consultants who you can email to ask to shadow. And then in your F2, try and get a surgical job. It doesn't matter for operative experience what subspecialty this is in, or sorry, what specialty this is in. So gen surg is a fine F2 job, orthopedics is a fine F2 job, even things like ENT, they all count, and points literally do mean prizes. The second section for commitment to specialty is whether you undertake a taster week or an elective in orthopedics. I wouldn't worry about this until you're a foundation doctor. Taster weeks are very easy to sort. You just need to email a consultant and ask to shadow. So if I was a first or second year, I think that getting involved in theatre can be challenging. I just don't think it's actually possible. The things you could do is get a surgical mentor from your local surgical society at your medical school, or from the British Orthopaedic Medical Students Association, and they may be able to assist you in other areas of the portfolio, or down the line help you get into theatre. If you're third, fourth, or fifth year, explicitly try and do student-selected components or electives in orthopedics. Email ortho consultants, be explicit, say you're interested in getting experience of orthopaedics, particularly operative experience, and ask if you can shadow their lists. The worst thing they can say is no, and that won't change the world. A bit of persistence is key here. So, quality improvement project and clinical audit. I've just briefly detailed what the max points here are, is that you are involved as a lead in all aspects of a surgically themed clinical audit or QI project that's demonstrated change. So an audit is comparison of existing clinical practice against some kind of guideline. It's important here to recognize that you guys are gold dust because as medical students, you've got a huge amount of time, which is things that your seniors often don't have, to undertake things like an audit. And don't ever think that, you know, people are doing you a favor by giving you an audit. Consultants have to do audits, and you're offering to do the bulk of the work and the lifting to get a clinical audit. And so you're really useful. And so the thing I would do is ask a mentor or ask an orthopedic surgeon, introduce yourself, say, hi, I'd like to undertake an audit. Things such as the British Orthopaedic Association standards, so BOAST standards, come in every few months and just say, look, I'd like to audit prior practice against this new clinical standard. And people will often be really supportive. So as I said, pick a guideline. Just ensure that what you do is you meet with your supervisor and get written credit for the audit that you've done, because this is evidence that you need to put into your portfolio. Make sure that you don't get possibly palmed off with just doing data collection while other people present the audit or take credit for the audit. If it's your audit that you're doing the work for, you need to get credit for this, and you need this in written format. The CST portfolio has got quite a clear guide about the evidence you need. If I was you, even when you're doing the audit, draft a letter that with everything that's needed under the current portfolio. Then once the portfolio has been completed and you've presented it, send it to your consultant and ask for it to be signed in the right format. Moving on to teaching experience. So I think that the maximum points here are for designing a teaching series and then delivering at least 4 sessions of that teaching. My recommendation here is to get involved in a student society or Medics&Me, in fact, because the people running this teaching series, I would hope are using this to get points for teaching experience for organizing a teaching series. So find a student society, be that surgical society, orthopedic society, and maybe as a first and second year, try and apply to be a conference lead or something like that to get some experience. And then in later years, I'd target being the events lead for your society or a co-lead or a president or something, and then offer to run a teaching experience. So I run a teaching set of teaching sessions. The key thing here is that you probably do have to do a reasonable amount of work for this. This isn't something where you can just tick a box. You've got to basically design the slides, set up the sessions, advertise it to students, and then deliver them yourself. You also need to work with a consultant who's a lead, which is why I recommend that you be a member of a surgical society, because they've already got these links to consultants that are interested in medical education. Just a few pitfalls here. Make sure that you don't accidentally wind up running a series on behalf of somebody else. This is a game and everyone's playing it. You don't have to reinvent the wheel, okay? You don't have to design high-tech teaching series. Just do something that is simple and easy to run. On the right-hand side here, we've got the research pyramid of evidence. And what this basically does is this summarizes the different types of research that you can do. It goes from things such as animal and lab studies all the way up to case reports, case control, cohort, randomized controlled trials, and then systematic reviews, strictly speaking, at the pinnacle. The way I would think of this, particularly as an earlier student, is think about the 2 major types of research. There's wet lab, which is primarily based in a lab, doing things such as genetics research, cell cultures, and dry lab. My personal preference is dry lab, and I'll expand on why. I would definitely recommend, if you're first and second year, look at undergraduate student placements. There's a thing called the Aspire Summer Studentship, and try and get some experience of a wet lab to see if it's something you enjoy. Again, you're gold dust, and finding a mentor is key because you have the time, you've got the summers as an early year student to actually put a good few weeks or months into a research project and then get outputs. Even as a 3rd, 4th, and 5th year student, you'd be surprised by how much free time you actually do have to do research of an evening when your seniors are normally stuck on call or just don't have the mental headspace to do this. getting in contact with the Academic Medicine Society at university can be useful to find a mentor. And the way that I would approach this is for your university, Google your university or your local hospital trust and orthopedic research. As an early year student, this is now your field of interest. Whether it is or isn't, this is the best way. What you need to do is you need to find a mentor who can then you can basically do the legwork for research for them. My recommendation is that you find someone that's a full-time researcher, such as a clinical academic. That'll sometimes be an academic clinical lecturer or professor in the topic, because I'm not certain, from my experience at least, people that are purely clinical sometimes lack the understanding of what's feasible and what isn't in research, and some of the research training background that can really help them to kind of educate you on how to undertake research. Because so what I'd do is find somebody from your local trust or local university who's involved in ortho research, email them, preferably with a CV. You know, it doesn't have to be a high-level CV, just saying that you're interested in doing some research in orthopedics. And then they should hopefully get back. And if they don't have time, they'll usually be quite supportive and direct you to someone that does have time. I think the pitfalls that I'd recognize in the early years is that this can be a massive black hole of time if you're not careful, particularly in wet labs. Your colleagues will have a lot of experience, and sometimes you can do research that just doesn't lead to anything in wet labs. And then it's unpublishable, your time is a little bit wasted. Another kind of pitfall is just ensuring that if anyone offers for you to do all of the work, collect all this data, run all this analysis, write it all up, just make sure that you are an author that reflects your contribution, and try and get that in writing, because can sometimes be cutthroat, the world of research, I think is a fair way of putting it. As a third, fourth, and fifth year, I might consider integrating, and this is working part-time, purely just for the fun of a year out of medicine, where you may have to work part-time, but this gives you essentially a really good teaching amount of education on research methods that you can then put towards doing actual research, rather than having to learn of an evening. If you do have to learn research methodology of an evening, the website Students for Best Evidence has a huge amount of just really good information that's targeted at a medical student level to explain what research is, how we do it, and why we do it. To do proper research probably takes years, and budget that in your plan. Also, probably all of you, I think, should be aiming to apply for a specialised foundation post in research. This has changed recently, but I understand about a third of places can be decided by your medical school. The worst thing that happens is you don't get in. But as a foundation doctor, this would give you explicit time, often 4 months or so, in which you can undertake research in. And if you're limited in time, there's some quick and dirty research that can be done. Letters to editors do count, although they count less than full research projects. And things such as med-ed research with Likert charts on a teaching program can also be presented. So I'll briefly talk about how I found the application process, and then I'll summarize with a few final kind of tips. So I've not done an interview for core surgical training yet. Mine's in a month or so it'd be unfair of me to comment. Oriel itself is quite annoying, but it's not that challenging. Okay, you just need to spend an afternoon or evening sitting down, working out the Oriel process, and you probably will be familiar with it from your application to foundation training. I think that if you build a portfolio that's appropriate for surgery, and you sit down and you tick out all of these boxes, you probably have more than enough to talk about at interview. But there is a certain amount of interview technique that you can gain. YouTube's got some really great guides for this. And if you're still an early year student, getting involved in things like public speaking, so getting involved in your medical school kind of student committees or debate. I think sometimes there are debating societies that are present with university, or just chatting to people. Okay, and these are kind of key skills, and often where you can see people perform less well is that they've got all these skills. They have the everything to talk about in an interview, but they just don't know how to adequately communicate it, and they don't know how to basically use frameworks that are common in interviews to get across how good they really are. What they're probably looking for is a well-adjusted, capable, and safe colleague. I'll briefly talk about this, but because we're well over time. But orthopedics has got a reputation, possibly, for being a male dominated specialty. And I think broadly speaking, the evidence actually bears this out. The British Orthopaedic Association is doing a lot of work to try and kind of improve this and change the culture in orthopedics. And so if you're somebody that's interested in orthopedics and you're a woman or you come from any of the other different groups, then there is a lot of support available for you, particularly targeted support. The British Orthopaedic Association has a web page designed for this, and I would go and have a look at it because things do need to change, and they hopefully are changing, but a bit too slowly, I think. I've got a whole slide here of a bunch of useful resources. The major one I'd look at the minute would be the Ortho Hub podcast, the British Orthopaedic Medical Student Association, and the medical interviews guide in the top left. So I've got some final notes. So everything I've said here is applicable to every single specialty portfolio. Don't focus on portfolio to the extent of everything else and then fail your medical school exams. You have to pass those still. But if you sit down tomorrow, you print out the CST guidance, and you create a to-do list for when you want to do each of the things like an audit or research, and then sit down and target them. Hopefully by the time you reach the start of F2, you should have them all ticked off and be ready to apply to core surgical training and therefore orthopedics as a specialty and perform well. Stay flexible and adaptable. So if you want to change and you want to do IMT, that's completely fine. A lot of people I know want to do surgery throughout medical school and then did a surgical placement as in F2 and decided, look, I don't want to do this. This is horrible. And that's fine. Try and keep in touch with any mentors or supervisors that you make along the way, updating them regularly about workload, because people will always come back. People come back to you years later saying, oh, I'm running this project. I remember you. We worked well in the past. Do you want to take part? Set realistic goals. So if you're going to do something and you commit to a senior that you're going to take a project, try and finish it. But if you can't finish it, just email them and say, life's got hectic, I can't do this. I think the worst thing is if you say you're going to do something and then you don't wind up doing it. It makes you look poor and a bit unprofessional, and it just leaves a kind of, it can quite slightly bad for your reputation. If I was you, I'd aim to try and do a surgical F2. I think as a surgical F1, it's got a reputation for being an awful lot of ward management work, and might not be as beneficial or reflective of the job of an orthopedic trainee. Don't let this take over your life. Try and exercise and spend time with your loved ones. And finally, I try and start as early as I can, because you can, over the years, build a really compelling body of work and connections without even kind of thinking about it or realizing what you're doing. And the next thing you know, you've got to, say, core surgical applications, and you've got a really great looking portfolio, and you've not really done a huge amount of cramming or work towards that. Thank you very much, everybody, and apologies for running over.
Talk a little bit about orthopedics. I really want to thank James. He had a fantastic talk, and amazingly has actually done a lot of the stuff which I was going to do. So I'm going to skip through some of the stuff which will be a repetition. So really, I'm going to talk about the longest bone. I'm a lower limb surgeon. I love orthopedics, and briefly about who am I? Well, I've been a consultant orthopedic surgeon now for 25 years. I graduated from the University of St Andrews. I trained in Cambridge. I've been the clinical director. I'm actually the chief examiner in surgery. So in other words, if you want to get out as an orthopedic consultant, you come and sit my FRCS exam. That's kind of what I do. I'm the president of the Chester and North Wales Medical Society. That's a brief background of who I am. But kind of want to talk to you about really orthopedics and why orthopedics. Margaret Mead, phenomenal woman. She's an anthropologist. She studied cultural traditions, really looked at what strong matriarchal societies were. And she was asked, what really is the first evidence of civilization? Is it farming? Is it fish hooks? Is it pottery? Is it weaving? Is it grinding stones? What is it? And she basically comes up and talks about what the answer is. But really, in terms of the way I see land use, language all developed at the same time. And really what's amazing about orthopedics and why I love it is that actually orthopedics, gory it may be, but actually it's not for the faint-hearted, but it allows us to make the lame walk. it's phenomenal in that it restores functions to arms and it saves lives. And of course, trauma is one of the biggest killers. Talking about Africa, you see that actually trauma is kills more people than AIDS, than infective diseases and HIV put together. And actually, trauma makes, and good management of trauma makes a huge difference. There are multiple careers to choose from. It's like this quest for the Holy Grail. We know which one are you going to choose from, and realistically, included in that, you also have the look. I want to live my life. I want to have party and a good time. I want to do my sports and sporting activities, and I want to meet up with my family. And you have to kind of balance all of that lot. But also, orthopedics does give you a huge amount in return for it. In terms of the variety which we see in orthopedics, it's just absolutely phenomenal. And there's multiple different options within orthopedics. James talked about the military, for example, and overseas and oncology. But in terms of doing hand surgery, elbow surgery, shoulder, foot and ankle, spines, pediatrics, etc., there's a huge variety of subspecialties to go into. In terms of what you would want to do, well, actually, let's just briefly talk about what is orthopedics. Orthopedics actually is a word which means ortho, which means straight, and pedion, which is from child. And so it originally was coined by Nicholas Andre, and he was talking about straightening children. And so the classic picture of the stake, which is there next to a tree, and as you strap the tree up to it, it corrects the tree in tree formation. That's where it was originally recognized from. And that's often a national and international symbol of orthopedics. We've already talked about undergraduate training, whereabouts you are, and some of you may have got through that and are into your clinical placements already. But normally you talk about the normal, and then we go on to, and James has already talked about where your choices are going to be, whether it's in hospital medicine, academic research, or other. Look, that we understand, and I fully understand the scale of the problem in terms of if you look from here where you're looking at 2010, where a large amount of people continued into training in the UK. Well, actually, as you fast forward and the numbers continue to change associated with this, large numbers of people are going to other destinations. They come back to come back into medicine, but we know that the number of people going into run-through programs is actually getting less and less as people look to take time out after their F2 year to kind of look where they're wanting to go. And I'll briefly talk about that in that actually, whilst you're going, if you are planning on going away, consider looking at the regulations before you do. What's going to happen going forward is that applications to core surgical training will limit the amount of time that you do in surgical specialities. Going forward next year, your foundation year's surgical experience won't count. But in this current cohort now, the foundation year placements do count as to the number of time you're allowed within the surgical specialities. In essence, what I'm saying is that if you are going to go away, have a look at the regulations before you do, and choose your specialities carefully if you are going to travel abroad before you come back here looking for it. There is a new exam which has come in around COVID time called multi-specialty recruitment assessment. You'll have to do this exam to apply for whether it's for surgery or other forms of surgical, other forms of training, obs and gynae, for example. I think medical training doesn't include this, and I think pediatrics have just stopped doing this, but they have a different type of examination or different types of portfolio review. But for you going on to surgical training, whether it's orthopedics or not, MSRA is going to be a component for you. There's multiple different types of questions associated with this. There's two sections with it. The first part is professional dilemmas, which is mapped to the GMC. It's situational judgment, prioritizing tasks, decision making, and that counts as 50 questions. There's scenarios, and then you have to rank them. There's scenarios with multiple options, and you have to choose the three most appropriate. And then there's also professional integrity and coping with pressure. This isn't, I'm going to tell you, an easy exam as far as I've seen it. You really between you and me, it's not what you would do, it's not what I would do, and it's almost not what's done in, a real life situation. But you have to kind of think, what would the GMC want, and what would be the most appropriate way of doing that? It's difficult to try and double guess these sort of things, but there are multiple places where you can look at these examinations online, and please have a go with them just so that you get your head into the correct space for it. It's the way I see it. Some of you may not get the quote, but it's almost like spinning leaf. You have to get your mind in a slightly different place to try and get this. And then the second part is like heart of stone, if you can get the analogy for it. This is predominantly clinical problem solving, and then this is tied into your foundation curriculum. And it's the second part, the extended matching questions and single best answer scenarios are given for this. If you score highly in that, you will then be eligible for interviews, exactly like James was. And congratulations, James, for doing well in your examination. In terms of the postgraduate training thereafter, once you get onto the core surgical trainings, there's the surgical examinations from the Royal Colleges. And talking about the Royal Colleges, even if you're in medical school, I would highly recommend that you have a look at one of the Royal Colleges if you are interested in surgery, and just sign up to them. Because actually there's a lot of information that there is on their website. They host multiple medical student conferences, and they also give lots of feedback in terms of how you structure yourself for the MSRA exam and also for the MRCS exams. And some colleges, like the Edinburgh College, will subsidize some of these exams for you. So have a look at those. It's not that expensive to join up at a junior stage. A lot of the expense for the colleges is when you become a consultant. So it's relatively cheap to join it, and it will give you information about it. The BOA also encourages, if you're wanting to orthopedics, the British Orthopaedic Association will also give you membership, and yet again have a look at it, and they will guide you towards what happens for this ST3 examinations. The ST3 used to be face-to-face, now it's portfolio review, structured clinical scenario. There's a structured interview around orthopedics itself to show your commitment to orthopedics, and then clinical prioritization. The clinical prioritization is something that you will get familiar with. You're almost set yet again, I'm not sure many of you will get the quote, but it's like the Kobayashi Maru problem in Star Trek. It's an unwinnable situation, and what they're looking for is to see whether you have going to choose something which is life-threatening before it's limb-threatening, before something which can wait but actually is urgent. And they're looking to see that you've actually learned that during your clinical years. This is kind of stuff which James has already talked about, and this is kind of guiding you towards what you need to do to put yourself in place. I'm going to say I just love orthopedics. It genuinely allows me to do amazing things. It's a huge privilege to have patients come to me and allow me to, in essence, open them up and put in metal and plastic and allow them to get up and get going. Hip replacements have revolutionized mobilization for people. Trauma and trauma rehabilitation has been fantastic. You get complex cases to deal with where you have to rebuild the bones, where you're actually putting in long rods or nails to reconstruct it. And of course, we have the technology with the Lazaroff frames or tailor spatial frames to regrow bone. Part of my job is also to do teaching, and I love to teach. I love to engage people and to bring them through into the career, which I'm passionate about, as you can see. You get to have a wide knowledge base. You have to have an understanding of plastics and rheumatology and oncology and hematology. You get training in actual practical hands-on skills with it, and also suturing skills. If you get a chance to do some of these, please book yourself in. The Royal College helps you with that. There are multiple useful resources which you've already talked about. As I say, the British Orthopaedic Association, the British Orthopaedic Trainees Association also has a section for medical students for it. Yet again, this is a link. This is a quiz for anyone. Please type into the chat room if you know what this link is. And I'll kind of come towards it at the end. It's a film. Anyone know what the film is? And the reason why I talk about this is that actually that's one of the longest bones, and that is a femur. And this is a patient which I literally saw in Ethiopia, where they come in and you can see that there they have a chunk of bone which is sticking out. That bone is dead. They basically want you to take it out, give it a wash and put it back in. In fairness, their body has healed around it. And what you've got is the sequestered dead bone being spat out by the body. And this is bone infection. So yet again, you have a huge variety of stuff which you come across and is amazing to see and amazing to help with. Look, you must choose, but you must choose wisely. I genuinely hope that you choose orthopedics. Why? Well, that's partly because what Margaret Mead said was the first signs of civilization was when she saw ancient cultures where the femur had been broken and then had healed. The reality is if you break a bone, you die. You can't run from danger. You can't, get to food or drink. And a broken femur, which has been healed, is evidence that someone has taken time to stay and look after you. Helping someone through difficulty is where civilization starts. And realistically, that's what I want to commend to you. Look, in terms of the summary for it all, get involved in orthopedics. Consider a SAMP if you're a student there. Your university may do placements associated with it. Learn the bones, especially the wrist and foot bones. Often we don't get taught that more than once, very fleetingly. And if you can just start naming the bones, I've got a whole talk on how you remember the bones, how you go around describing fractures. And yet again, I'm happy to do that as a lecture for you in the future if there's enough demand from all of you coming back to Medics&Me. I'd be glad to help out with that going forward. Look, talk to your friendly neighborhood registrar, go and do an on-call with them, help them out if you're a student, do the audits, do the research, come and speak to us consultants. There's a fundamental fear that, someone's going to say no. And as I think James is absolutely accurate, if they're going to say no, you are no worse off than not having asked, don't, shyness does not win you points, just ask and you will be surprised by how many people really want to help you. If they have helped you, please tell them how you're doing. Often there are many people I've helped in their career, and you kind of meet them again at the consultant interview. They'd love to see how you're doing. We are medics at heart. And I'm going to say, Megan was like mildly apologetic over calling me a doctor. I'm a doctor first and foremost. You lose your doctor status, but when you become, FRCS, but nonetheless, we're doctors first and foremost. And which really gets me to, what I was saying is we are at our best when we serve others. That's why I do orthopedics. It allows me to make people better, quicker, faster. And it is a huge privilege to do that. It's absolutely right that we need more diversity. It's absolutely right that we need more women into it. The way that's going to happen is that you join and you do this, and we would be really grateful. I would be really grateful if you do. So that kind of gets me to the end of my talk. It gives us a chance to ask questions about orthopedics. Any comments that you have for me, I'd be grateful to field, and then we can have a chat about it at the end. I'm going to kind of switch this off and stop sharing.
Oh, thank you so much, Mr. Rao and Dr. Prowse. That was very informative and very helpful. I have a question for you, if that's okay.
But James first, go ahead.
What would you say is the hardest bit about being an orthopedic surgeon? Or the bit you
I'll defer that one to Mr. Rao, actually, because he actually is.
a lot of it is stickability. Okay, I can kind of break that down into a couple of things, really. So part of it is stickability. I think that I do it because I love helping people. A lot of my colleagues love it because they love operating. They love the technical aspect of operating. They love being in theatre, and I think that's a great virtue. It's really fantastic if that's what's going to happen. But for me, it's the actual ability to make people better, and it's really tricky because actually orthopedics is a very competitive specialty, and you find that that picture which James have with full of ortho bros. It's a difficult environment to be in if you don't automatically fit into that category. And I'm going to tell you, nobody fits into that category. A lot of the people who claim to be ortho pros are also trying to kind of fit into this funny, made up, perceived element of it. But you will find that there are lots of people who have very short synapses. They are very quick in response. They are very direct people in orthopedics, and often that means that when people are new and they feel insecure about whether orthopedics is the right career, even though it is the right career for them, they go, "Gosh, I'm just not like that." And I think that that's a real fundamental pity because you need to have that stickability to go, "Look, I don't want to be like them, but I love this subject. I love making people better." And orthopedics, more than anything else, makes people better, quicker, faster than almost any other specialty that I can think of. The only other thing that I would kind of say is slightly different from that is ophthalmology. You make the blind see, but for orthopedics, you make the lame walk. You give them their function of their hands back. You give them their life back. It is genuinely amazing. Genuinely amazing. James, can I hand
Thank
over to you?
you.
And I'll kind of echo just a point from and as a foundation doctor. So my strong assumption is that most people here are from a medical student still. Just recognizing that you are in a genuinely amazing position where you have more free time than you will probably have for a prolonged period of time. And to try and just enjoy it and also utilize and plan. You've taken the first step by coming to a talk like this to learn about what a career is like and the steps you can take. You are gold dust and you're really helpful for a huge number of your seniors for in a bunch of different projects. A couple of hours a week. Say you could become a senior member of the Medics&Me as part of the national committee, for example. If you do just a little bit of stuff, you can help set your career up for down the line and gain a lot of skills because possibly as a foundation doctor, you all know what it's like. You read the news, you can get stuck in an awful lot of service provision. And in reality, applications to specialty training are in the second or third month of your F2. So as much as of this kind of work that you can get started as a medical student can really help set you up and make things so much less stressful down the line.
Oh, thank you. And I just wanted to also ask, do you have any advice for girls like me who may be interested in surgery or anything like that?
Yes, just do it.
Yeah.
Just do it and don't let anyone stop you. Just do it, because it is such a joy. The thing to remember fundamentally is the patients. Remember the patients. You make them better. You make them better. Dare I suggest it? I think, if you have good communication skills, you look after them, you care for the patients, they notice it and they will get better. The other thing which I kind of also want to say is that is especially for orthopedics is that the reason why you almost end up sub-selecting people who have got short synapses, if I can put it like this, who are much more brusque, is that they also operate quicker. There isn't a hesitancy associated with it. So they get down to the bone, fix it quicker and get out quicker. And so part of it is that you have to train yourself while you operate is to move at pace. Because often when you have a degree of natural reserve, you go, am I doing the right thing? What could go wrong? Then actually it does slow you down. And so if there's one recommendation I would give you is to say, just consider moving quicker during your operating time. What would make me more efficient? Have the internal dialogue being, how can I become faster and more efficient at this? Because that's really key. The quicker the patients are off the table, the less likely they're going to get complications. You just have that set in your head, then that's what I would urge you for.
Thank you very much.
Yeah. And then without going into a whole of evidence, but I think from what I understand, the evidence base shows that for the orthopedics is basically losing interest from women at a medical school level. That's when like opportunities by the profession are missed, and we fail in this regard. I think the major things can be unsociable hours and on-call commitments, but there's things that we can do and we are hoping to do, such as outreach, undergraduate training. So if you look at the British Orthopaedic Medical Student Association, which is a mouthful, but is called BOMSA, as part of the BOA, they've got mentorship schemes there. So if you go on their website, as I did about 5 minutes ago, if you go on their website, they've got mentorship schemes. And there were people who are current trainees in orthopedics who are desperate to help and provide support, particularly to sort of female trainees to female medical school undergraduates, which would be really helpful. That's one avenue. I'm certain there's many, just a kind of Google.
Yeah, Royal College of Surgeons in England. I'm linked with the Edinburgh College, but the Royal College of Surgeons of England have got lots in terms of supporting women and getting women through into surgery. And there's a specialty subset associated with that. And I'd highly commend you to look at that too. There are some questions coming up through in the feed. One of the questions which I have from AA is, when you subspecialize, for example, in hips or knees, does it become a struggle to retain your competence and manage the general on-call? And the simple answer is no, because you do the general on-call regularly. So, you know, I've got clavicular fractures, I've got pediatric cases where they've got elbows, where they've got supracondylar fractures in there, and you have to deal with kids. You know, you deal with distal radial fractures, you deal with glass lacerations in hands, you deal with you know, foot and toe fractures or crush injuries. So in essence, that's the great thing about your training, is that you fall down to the highest point of your training, and the training, I'm glad to say, in this country is exceptionally good, and I kind of commend it to you. The simple answer is no. You know, here I am 25 years in, and I've been dealing with complex trauma realistically the whole of my time, and still enjoy doing so. Does that answer the question?
I think the next question's from H, and I guess I might answer it first purely by saying, so I'm not sure how I can build my career in TNO. I've been a TNO JCF for the last 2.5 years. I'm very prepared for MRCS, but I feel terrified due to competition in the field to get into a training pathway. So well done. You're doing preparation for MRCS. I think the way I'd describe it is there are hoops you have to jump through. Okay. We've detailed them. The first one is the multi-specialty recruitment exam assessment, and the other one is portfolio. So if I was you, the portfolio is a roadmap. Work out what you need to do to get more portfolio points, and then speak to your seniors if you're in the department and ask to do explicitly fill all of these things in. This is a bit of a faff and takes a while, but there are other things you can do quickly to get the points. And then remember, you have to do well in the multi-special recruitment assessment to even get a hope of an interview. I will argue that I possibly could have prepared more for this exam. I did well enough, but I know people that did well that basically sat for almost a year. They did past medicine, they did the question banks twice over, and those are the people who scored the highest. I don't think that when it comes to situational judgment, these are unrevisable. I think they actually are. You have to learn the underpinning thinking of the bodies that kind of decide what is a more professional, but these are revisable. And the clinical questions, they're broader medicine. You may work within an orthopedic department or something, but these questions are revisable. You can learn. Just practice, practice, practice is my advice. That, you know, I could have followed better. We aim for perfection, but we don't always hit it.
Well said, James. I think you're right. This is a highly competitive field. It depends on what what you want to do, and I think it's worth applying. You never know. That's the first thing. Number two is they have to give the job to somebody. Why not you? And you have to have that mentality. Number three, surgery is terrifying, and unless you kind of understand where that fear comes from, it's your volition to do well, not just for yourself, but for your patients. You keep that as a central focus. Actually, you can't go far wrong. You can't go far wrong. So all I'm going to say is throw your hat in the ring, look at the rules, jump the hoops. These are just the set of hoops here. We dream of an ideal world where, it's easier for someone else. And I was just discussing actually with my mentor. He was a chap who was my consultant when I was a trainee. And I've just met up with him. He was ex-SAS and he was early on in his career, he was chatting to someone, his mentor, and he was saying the grass is always browner on both sides of the fence. It was his take on it. You think it'll be better, but actually there are just different hoops in different places to jump. You just have to choose which hoops you want to jump and where your passion lies. And actually, sometimes your passion, you don't know where your passion is. I'm going to tell you, at medical school, I was going to go off, probably be a GP, probably be a cardiologist. That's where I was heading. I ended up, as James was suggesting, I did an intercalated year. I just happened to do it in chick limb bud development. I didn't think I was going to go into orthopedics, but all of a sudden, the orthopedics doors opened for me by doing that. I probably wanted to do plastics, but actually I enjoyed orthopedics more. My mind is set up that way. So it's difficult to prejudge. You can always choose to opt to do something else. Keep flexible. But if you enjoy that, go ahead and do it. Go ahead and make people better. We need good doctors like you.
Thank you so much for having me. I'm happy to share all of my slides. So if you fill that form in, we'll be able to share it. And keep in mind that Medics&Me offers a huge amount of mentorship opportunities and future leadership opportunities. So if you're a mentor, I was a mentor for Medics&Me for a year, and then I was able to use that to do something within the national committee. And I'm still involved, but less than I was in the past. It was a great experience that I am fully planning on talking about in my core surgical trainee interview. There's a question about leadership. This is literally what I'm going to talk about because it was so useful and beneficial for me. It doesn't have to be a huge amount of work for you, but you can actually help to improve people's entry into medical school. I'm sure Meg might have a bit more to say at some point.
Yeah, the thing that I would say, guys, is with Tony smiling because she's like, I know exactly what's coming here. But what we want is this stuff can feel really overwhelming and really scary. And actually, we want, through the vehicle of Medics&Me, for this stuff to feel accessible and well supported. And the things that you do have such a clear purpose of supporting other students. So we can kind of be a vehicle for you to support other students who need it, gain skills, get a network, understand how all this stuff works. We'll set you up with the springboards to do it. And then that can then give you the confidence and the knowledge to go and do it elsewhere and know that you've had that fulfillment of supporting students. The thing that we feel really passionately about is we don't want these things to be a tick box. Obviously, what these guys have spoken about here are very powerful experiences, but sometimes people can end up doing things for the sake of it or to tick a box. And we want to provide opportunities where you come away from it feeling empowered and confident, having gained skills, all while supporting other students, not kind of having turned up somewhere, felt a bit used, not got a lot out of it, not got the evidence. And that's my little plug for Medics&Me. So if you want to come and join us, if you're interested in any opportunities, we are always delighted to have new people, and we're getting new schools all the time. So the students are there and want to be helped. So you are all so welcome to join. Follow our socials, drop us a message, apply on the website. And yeah, thank you so much for coming.
Brilliant. If there's no further questions, I really wish you well. I genuinely hope that, this gives you a degree of confidence to go, look, lots of people are doing this and I can do it too. I mean, that's the real mindset. That's what I want you to take away from this, is to go, look, there's no reason why it shouldn't be me. Why not? Why not me? And in essence, I had that mindset. Sure, it was difficult, but actually, oh my gosh, I am so delighted I made so many people better. It's a great career. I commend it to you.